Okay, well, let's do fluid and electrolytes, specifically hypokalemia. And our exemplar for this is heart failure, which is exemplar 16F. I'm aware that you learned about heart failure back in level 2, but we get to talk about hypokalemia. So I'm going to take this as a good opportunity to review heart failure for you because that's important. Heart failure is probably the most readmitted DRG that we have, so we see lots of people with this. So start with the patho. Heart failure means that my heart has the inability to pump sufficient amount of blood to meet the demands of the body. It's really impairment of the ventricles in either filling and or pumping. And it occurs because we've had an insult to our heart, which means our heart has an inability to pump correctly. When our patients have heart failure, they actually have a lot of compensatory mechanisms going on to help improve that decreased cardiac output that they have. These compensatory mechanisms can be in place and working for over 6 months before they actually ever develop any symptoms. So those compensatory mechanisms come to work because our baroreceptors, which sit in our carotid arteries and our aortic arch, get the sense that we have decreased cardiac output. So it says, hey, let's fix this. Fundamentally, our body does not know why we have decreased perfusion. It just knows that we have that. So what it says is heart beat stronger and faster. So that doesn't help a heart that's already failing in heart failure where it's having an inability to pump. It says lungs. You help by breathing deeper and faster because maybe it's an oxygenation issue. Then it says periphery. Why don't you help? Maybe this is actually a vascular issue, and let's vasoconstrict, increase our afterload, our systemic vascular resistance out in the body, the resistance my left ventricle has to overcome to pump blood out to see if we get more perfusion. When afterload is increased SVR, that makes that heart have to work even harder. Then the kidneys kick in and say, hey, we can help. Let's retain sodium and water so we have more volume, because maybe it's a volume issue. So none of that helps, but that is just compensatory mechanisms for decreased perfusion. So we do have some classifications of heart failure. You will hear left-sided and right-sided. So left-sided is lungs. The way you think about this is you've got to remember blood flow through the heart, and if you have problems with that, you need to go back to module 1 and look at the blood flow through the heart information that's there. My left ventricle pumps blood from my left ventricle through the aorta out into my body. And if I have too much fluid, I can't pump blood forward and it tends to stay there. I say that it backs up. It doesn't flow backwards, but that's just how I think of it. And it's going to flow back and be in their lungs. So left-sided heart failure has lung problems. Right-sided is the rest of the body. This is the right side, the right ventricle, who can't pump blood into the lungs. The blood is backing up and we see symptoms outside our body like edema. The other terms you may be more familiar with are systolic failure and diastolic failure. Systolic heart failure is the inability of the left ventricle to pump correctly. Diastolic heart failure is the inability of that ventricle to fill correctly. We all know that when we don't pump well, we don't have good cardiac output. But if I don't fill the chamber either, even if I have a great pump, I don't get good output. The newer terms that you hear for that are heart failure with reduced ejection fraction, or HFrEF, HFrEF, that's systolic, or heart failure with preserved ejection fraction. And that means that I pump well, but I'm not feeling well. So the newer terms from systolic, diastolic is HFrEF and HFpEF. So I wanted to put those on there for you. And this is really all when we do HFrEF, HFpEF, we're looking at the ejection fraction. If it's less than 40%, 50 to 70 is normal, then we have reduced ejection fraction. If we have 50 or higher, then we have preserved. Causes of heart failure: MI, hypertension, cardiomyopathies, valvular disease, like aortic stenosis, blood can't come out, diabetes, endocarditis. All of those are the causes that can lead to heart failure. Okay, so let's talk about these clinical manifestations. So I did find a little left versus right heart failure that I put it in your outline, and it's here. You got to be able to click on it and make it bigger to help you with the difference between left and right. Left is lungs and right is the rest of the body, so that should help you. Cardinal symptoms: dyspnea, fatigue, exercise intolerance, and then fluid retention. If I have pulmonary edema, fluid sitting in my lungs, that is left-sided. If I have peripheral edema, that is right-sided. The number one cause of right-sided heart failure is actually left-sided heart failure. It's gotten so bad that it builds all the way up from the left over to the right out to the periphery. So sometimes heart failure is just heart failure. We do not distinguish between left versus right. But sometimes it's important to do that, especially because they do have different clinical manifestations, so you do need to understand the difference. So left-sided, you're going to have fatigue, activity intolerance, dyspnea, cough, PND, having trouble breathing at night. These are people who have to sleep on several pillows to raise themselves up because they have fluid in their lungs, and during the day that fluid is accumulated down in the bases of my lungs. But when I lie down at night, that fluid now is all along the posterior surfaces of my lungs, and they have much more increasing shortness of breath. They will have crackles, they will have gallops, an S3 or an S4, so make sure you know what an S3 and an S4 looks like. Right-sided, that is your weight gain, edema, JVD, liver and spleen engorgement. They have nausea and vomiting and anorexia because they've got engorgement and everything, engorgement throughout that GI tract, and they don't want to eat. The biggest complications for heart failure is pulmonary edema and cardiogenic shock, because cardiogenic shock is a heart that can't beat and they're trying to be dead right there, and their signs and symptoms are heart failure. So let's talk about our diagnostic tests. So there's several things that we can do. We can get a chest x-ray. We will see findings of pulmonary edema or heart failure on the chest x-ray. We could get an echocardiogram to look at the pumping of the heart. We could do an EKG to roll out the fact that my patient's having an acute MI. But the one lab that is most specific is BNP, B-type natriuretic peptide. And a normal value of that is less than 100. That is excreted by the ventricles due to wall stretch. So I don't know if you remember back in pathophysiology or A&P that you learned about Stirling's law. So think of a rubber band. If I have a nice new rubber band, I can pull it big and it's going to snap right back to its original size. And I can pull it out and it's going to snap back. So that's your ventricle. But just like a rubber band, if you sit with a brand new rubber band and you pull it and stretch it and 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 do that over time, the fibers of that rubber band are going to break down and it won't stretch back and go back to its original shape. Same thing happens in your heart. So it is used to distinguish what kind of dyspnea we have, because maybe we have somebody with coronary artery disease and we're like, is this a respiratory problem or is this actually a cardiac problem and I have a high BNP? The important thing too is to correlate the value with your patient's symptoms, because we will see a lot of patients who come in who have elevated BNPs, 500-600, they don't have symptoms and nobody's really worried about that BNP because they don't have symptoms. So if it's elevated and they have symptoms, that's where we get concerned. Now let's talk about our hemodynamic values. If you haven't listened to the hemodynamic lecture, that's okay. This is going to make more sense when we get to that, because I'm really going to incorporate that between this content and when we get into our perfusion type part 2. So hemodynamics, our preload is volume, so it's how much volume is in the heart in that ventricle at the end of diastole at its fullest. Well, in heart failure, my volume is elevated. Afterload is the resistance I have to pump against, that left ventricle has to pump against to get blood out of the left ventricle. That's going to be elevated because we have vasoconstriction going on because of poor perfusion. And then, of course, contractility is low because I have poor pumping. And when you get hemodynamics down and understand how to treat hemodynamics, you actually know how to treat all of these conditions. Look at collaboration. These patients are going to have healthcare providers. They're going to have cardiologists. We'll probably need respiratory therapy. We need a dietitian, pharmacist. They may need PT, OT, and cardiac rehab will be a good idea for them as well. So pharmacology. These meds are not different than any meds that we know. Cardiac meds, ACE inhibitors. They could be on ARBs. They could be on what's called an ARNI, which is a combination med, and those have come out in the last several years, and patients are using this for heart failure and doing really well. You have examples of those meds in your outline, so be sure and look at that. They're going to be on beta blockers. They're going to be on inotropes. So I use the term inotrope. Sometimes they're called cardiac glycosides because inotropes improve the contractility of your heart. So the one you know the best is digoxin. It slows and strengthens the heart. So we can use that, but dig isn't being used much any longer because it has a very narrow therapeutic window and patients tend to get dig toxic on it, and it is not an emergency med. Our other medications are dopamine, dobutamine, and milrinone, and those are IV drips used solely in the ICU. We will have diuretics. We can have vasodilators. And then this is new to you, and you need to put a big star on this because this came out in the last couple of years. Patients with heart failure are being started on sodium glucose cotransporter 2 inhibitors, so SGC2I medications. And Farxiga and Jardiance are those two common ones. And yes, these are diabetic meds, but what it is doing, it is decreasing mortality for them and improving their life. So regardless of whether or not they are diabetic, we are starting heart failure patients on these SGC2I meds. So put a big star on that. You do need to remember that. They will also have management from fluid volume management. These are people who need to have saline-locked IVs. They don't need to have IV fluids running at 50 an hour because when you calculate what that is over the course of 24 hours, that's enough to put them into volume overload. Okay, so let's talk about the treatment. This probably is a little different than how your book uses it. This is a previous resource that I've used, and it just makes more sense. It's a book plus an article that I read about heart failure and what we need to do. So I put it together for you because it just hits the vital points. So during the crisis, we've got to support cardiac, respiratory, tissue, and renal perfusion and function. Because if we're not doing any of that, if my heart can't pump, I'm going to have respiratory problems because I'm going to be in fluid volume overload. I'm going to have poor tissue perfusion everywhere, and I'm certainly going to have decreased tissue perfusion to my kidneys, and they're going to end up in acute kidney injury. We need to take care of fluid and electrolyte problems because these patients, when we treat their fluid volume overload and give them diuretics, they are at risk to become hypokalemic and lead to lots more problems. They're going to have volume overload issues, and then they're going to have nutritional issues. And nutrition for a patient in heart failure can be difficult. So when you think of medications and nursing care, nursing interventions, this is what you need to think of. The first thing we're going to do is improve pump function. And those are our first line medications of giving ACE inhibitors, ARBs, using diuretics, beta blockers, dig, inotropes, improve pump function. Then we're going to reduce cardiac workload. And as a nurse, this is really what the things that I can do. I can cluster their care. I can help them with their ADLs. They need to send them to cardiac rehab. We need to optimize their gas exchange. So evaluate their airway, their respiratory function. What's their O2 sat? We may need to do ABGs. So think about what you think their ABGs are. If they've got a lot of fluid, they are not having good gas exchange, and they're going to retain PaCO2, and they're going to be in respiratory acidosis. So we may need to provide oxygen, elevate the head of the bed. If they get bad enough, we might need to intubate them. We need to aggressively diurese them. The goal is euvolemic, which means equal in, equal out. So that should tell you some of the things that are important for us to do when you think of giving diuretics. We also need to do our daily weight. That is the best indicator of diuresing. And remember, 1 kilo is 1 liter of fluid. We need to treat the underlying cause. So if the underlying cause is heart damage, they need to go to the cath lab. They need to go to bypass if they need a valve replacement. If it's could even be conduction disorders, get them an ICD. Whatever it is, let's treat that underlying cause, because if we don't do that, they're never going to get better. Certainly restoring them back to sinus rhythm so that we have better pumping, better cardiac output coming out will help them, because they will be prone to having things like atrial dysrhythmia. Then we need to look at further complications and exacerbation, and this is really where the education comes in. So in your folder in Blackboard, I have given you some resources. I've given you a short video to watch. In there's going to be a link to kind of explaining the difference between HFrEF and HFpEF. And then there's a handout from American Heart Association for patients. And it's a one-page handout, and it's got green, yellow, and red. So you think of a stoplight. Green is good. This is what's going on with me. That means it's good. Yellow means I need to start paying attention because I'm having some newer signs and symptoms. And red is I'm in trouble and I need to seek medical help with that. So you need to look at that, because what we need to do for these patients is to find out where they've been. If they are coming back into the hospital within 30 days, they're hitting big alarm bells that there's a problem for that. And we may not get reimbursed for that second hospitalization. So we need to decide what the problem is. Did they go home and decide to be non-adherent and just not do what they wanted to? And so, you know what? I'm going to eat chips. I'm going to eat ham and cheese sandwiches every day. And I'm going to go and get a 44-ounce Dr. Pepper at Sonic and drink 3 of those today. Their choice. Maybe they don't want to take their medications. Maybe we sent them home too early and they weren't where they needed to. And maybe we didn't do our job and educate them correctly about what they needed, which is where this collaboration is so important, and cardiac rehab, so that they can learn to do what they need. So we need to start this education early in the process. Now, if they are critically ill, not the time to have those conversations, but as they're improving, we need to sit down and say, let's talk about what you've been doing at home and see what they've been doing, where they're having problems, give them clarification, and give them the resources that they need. So this is just vital to what we need. They need to know what early recognition of a worsening signs and symptoms are and what to do for it. That kind of seems a little funny to me as a nurse, but I'm a nurse and I get all this. So we just have to tell people if they have worsening shortness of breath, if they have new or increased swelling, if they have a weight gain of 1 to 2 pounds in a day or 5 pounds in a week. There's no real standard for this. This is going from American Heart Association. If they're starting to develop nausea, poor appetite, chest pain, pressure, tightness, new irregular heartbeats or palpitations, trouble thinking or increased daytime sleepiness, drop in blood pressure associated with dizziness. Those are all signs that they need to call their healthcare provider and they need to be seen. And if these are really bad, like I can't breathe and I'm really lightheaded and dizzy, they need to seek emergent medical treatment. So we need to go over these with them. Lifespan considerations. We don't see heart failure a lot in children. It's really associated with congenital heart defects, and we've already talked about that. Difficulty breathing, sweating, low blood pressure, poor feeding or growth are some of their clinical manifestations, and certainly we're going to give them diuretics and some afterload reducers, which would be things like antihypertensives. In pregnant women, their symptoms can worsen because of that increased blood volume that you get with pregnancy. And so if they have heart failure, they can become decompensated. Other causes are peripartum cardiomyopathy. So this is women who develop cardiomyopathy, which is a very large heart. Large hearts do not beat well and they do not conduct well. And cardiomyopathies can be a leading cause of sudden cardiac death. So you can develop that just from pregnancy. Preeclampsia, chronic hypertension, we are seeing that. We have populations that are having more hypertension, and we are seeing actually maternal deaths because of hypertension. And also if they have pulmonary hypertension, which is more pressure into those lungs, and that would be our signs and symptoms of that would actually be right-sided heart failure. They're going to be treated with ACEs and ARBs. The ACEs and ARBs are contradicted in pregnancy, so we would have to change their meds if they are taking those. So if they have pre-existing heart failure, they've absolutely got to have conversations with their healthcare provider. Older adults, heart failure increases with age. My grandmother at 99 had heart failure because she was 99. She didn't have any other reason to have heart failure other than the fact that she was just old and her heart was getting really tired. Symptoms are more gradual and may actually be dismissed, that they think, oh, this is just happening because of my age. Certainly they very well may present with hypertension because that is very common for them to have, and some pulmonary edema. And we do have to worry about drug interactions and non-adherence with medications. With our education, we certainly need to talk about medications and talk about income, and do our patients have accessibility to cardiac rehab, medications, driving, food, being able to get the resources that they need. So that adds to our interdisciplinary collaboration list that we have. Okay, so I'm going to share with you some American Heart Association, American College of Cardiology guidelines for heart failure, because this kind of tells you what we need to do. So you can put a star on this because this is really helpful. They need detailed discharge instructions, verbally and in writing, and certainly in the language they speak. So it's very easy to get American Heart in Spanish because it's on the internet, easy to do. We need to talk to them about recognition of escalating symptoms and what to do, and we just talked about that. Activity and exercise recommendations. These people need to have activity, just like they do for cardiac disease, 150 minutes a week, which is 30 minutes a day for 5 days a week. Now, are they going to be able to do that? Probably not, but can they start with 10 minutes? Yes, and we can build up from that. They need a low sodium diet, so that's where that 2 grams sodium is going to come in. All discharge medications, specifically if they've got left ventricular ejection fractions less than 40, they're going to be on beta blockers, ACEs, ARBs, or an ARNI. They need those SGCT2I medications. They're going to need to weigh themselves every day. I would always teach them that you need to get up out of bed, go to the bathroom so you get rid of some weight, and then stand on the scales and write it down. And if you have 1 to 2 pound weight gain overnight, that's cause for concern. If you have 5 pound weight gain in a week, that's cause for concern. Because 2 pounds, 2.2 pounds per kilo, a kilo is a liter, they're a liter ahead. Now, it's up to the provider whether they are going to go home on a fluid restriction. If they are well maintained with heart failure, they may not have a specific written fluid restriction, but we do need to talk to them about if you're eating foods high in sodium, you're going to want to drink more water, and they do need to just be careful and not be drinking like 4 44-ounce Dr. Peppers every day. We need to modify any risk factors that they have. So those are coronary artery disease risk factors. And we need to do smoking cessation advice or counseling, whatever we want to call that. So that's all important. So there's lots of health. Um, I just lost the client need category. Health promotion and maintenance. Sorry about that. I just had a big brain fart. I talk about that one all the time. That's education for these guys. All right, last topic. Let's just hit on this hypokalemia because that's why we're supposed to be talking about this. We know that a normal potassium is 3.5 to 5. A critical value is less than 2.5, which means we need to do something. So the clinical manifestations for that are things like ventricular dysrhythmia. So VTAC, VFib, both of those can just be dead. They can have flat T waves or U waves. So a U wave comes after the T, before a P, and it is not a T and not a P. And when you see a U wave, the first thing you should think of is hypokalemia. You also have flat T waves. We kind of lost the T wave, so I found this example for you. We can have anorexia, decreased bowel sounds. They can have an ileus, muscle cramps and weakness. They can have muscle weakness in their respiratory muscles, leading to inability to breathe well. So it's imperative that we keep potassium levels where we need. And if you give your patient a diuretic, you should check a potassium every day. So if your patient's been ordered a diuretic, we should be checking a potassium. And if it's normal or just slightly low, 3.4, probably nobody's going to care and get excited. But if it's 3, less than 3, certainly at 2.5, those are critical values, and we should give potassium. You give it IV piggyback. Never, ever, ever do you give it IV push. That would kill your patient. And you need to check your policies at your facilities. Most facilities require that if you're giving IV potassium, you have to put the patient on a cardiac monitor. If their potassium is just slightly low, we can give it IV or a PO so they can take a tablet. We can use a liquid. I've had people drink the liquid. Tablets can work. Certain tablets you cannot crush and put down an OG tube. It will occlude them, so we use the liquid for that. Whatever we need to do to give them that potassium. All right, so I hope that has jogged your memory on heart failure. Thank you.